Welcome to Clinicals with PHARM VIC. Today, I will be talking about pain. Before starting treatment, assess the type and severity of pain. Pain types. Pain may be classified clinically as nociceptive, which involves the activation of normal pain fibers in response to a noxious stimulus, for example, injury, disease, inflammation, somatic, for example, involving superficial structures such as skin and muscle, or visceral, for example, involving deeper organs such as liver, pancreas, neuropathic, which involves injury or disease affecting the peripheral, for example, diabetic neuropathy, phantom limb, or central, for example, spinal cord injury, post-stroke, nervous system or both, like postherpetic neuralgia, mixed nociceptive and neuropathic. For example, some cancer-related pain. It is important to distinguish between nociceptive and neuropathic pain as they respond differently to drugs and other treatments. Knowledge of the anatomical and pathological origins of pain. For example, bone metastases, nerve root compression, infiltration, or postoperative may help to determine the type of pain. Pain may also be described as acute or chronic. Pain assessment. Pain is subjective and cannot be measured directly. Use of self-reported pain intensity scales alone can risk overprescribing of analgesics, particularly opioids. Pain scales used to assess intensity of pain include numerical rating scales that rate pain on a number scale. For example, from 0, no pain, to 10, worst pain imaginable. Verbal categorical rating scale that uses words to describe pain. For example, none, mild, moderate, severe, worst possible. Wong-Baker Faces Pain Rating Scale, which uses pictures of faces with different expressions to rate pain and is used in children 3 years. Pain assessment involves more than quantifying pain intensity and should incorporate an objective assessment of the functional impact of pain. STIMAS. One assessment tool that can be used at the point of care is a simple functional activity score. A. No limitations due to pain. B. Mild limitations of activity. C. Significant limitations, unable to complete activity due to pain or treatment-related adverse effects. When a person is unable to report pain, for example, young children, cognitive impairment, psychiatric pathology, observational assessment of behavior is necessary. For example, CRIE's Pain Rating Scale for neonates, FLACC Behavioral Scale for infants and children, ABI Pain Scale for dementia patients. For chronic pain, the Pain Enjoyment General Activity Scale, a brief 3-item validated pain score, allows assessment of pain severity and its physical and social impact. When to start treatment? Pain is best treated early because once established, it is more difficult to treat. In addition, there is increasing clinical evidence that appropriate early, aggressive management of acute pain may minimize the transition to chronic pain. Drug choice. Use analgesics as part of an integrated multidisciplinary approach. Tailor the analgesic to the type and severity of pain as well as to the patient. Titrate the analgesic dose against pain relief and unwanted effects. In most patients, multimodal analgesia should be used, with the aim of increasing pain relief while minimizing adverse effects. Methods include analgesics, local anesthetic techniques, for example nerve blocks, epidural or intrathecal analgesia, disease-specific treatments, non-drug techniques, and attention to psychosocial issues. Oral. Use the oral route where possible. If allowance is made for bioavailability differences, this is as effective as parenteral administration in most cases. Use a conventional release product for acute pain, dose titration, initial treatment and unstable pain phases, and for breakthrough and incident pain. Soluble or effervescent products may have a more rapid onset of effect than tablets or capsules. Buccal lozenges or tablets or sublingual tablets also have a rapid effect. Controlled release products are useful for chronic pain, but are not suitable for acute pain because of slow onset of effect. This makes rapid, safe titration impossible. Parenteral route. Intravenous administration is preferred for acute severe pain, for example postoperatively, but is not appropriate for chronic pain. Subcutaneous administration is as effective as the IV route.
Or
It is used for intermittent doses and infusions of opioids in acute and chronic pain.
or
IM administration is painful and absorption may be erratic.
or
It has no role in cancer pain relief and is becoming less common in managing other types of pain.
or
Patient-controlled analgesia, PCA by IV or SC routes gives greater patient satisfaction and better relief of postoperative pain than conventional methods of administration. It requires special infusion pumps and education of patients and staff. Other routes. Transdermal patches containing opioids are appropriate for stable chronic pain, although the dosage is relatively inflexible. They are not suitable for acute pain because delayed onset and prolonged action make rapid, safe titration impossible. Do not use fentanyl patches in opioid-naive patients as the risk of toxicity is high. Inhaled nitrous oxide in 50% oxygen or methoxyfluorine in sub-anesthetic concentrations may be useful short-term, for example, labor and delivery, during ambulance transport of patients, dressing changes. Epidural, intrathecal, or regional nerve blockade is effective but requires additional monitoring, equipment, and staff education. Rectal may be an alternative to parenteral administration. Non-drug treatment. This includes cognitive behavioral therapies, heat or cold applications, massage, exercise, immobilization, transcutaneous electrical nerve stimulation, TENS. Cognitive behavioral therapies. Relaxation techniques and massage are beneficial in chronic pain, but evidence for their efficacy and that of other non-drug methods in acute pain is inconclusive. Surgery and invasive procedures, including neural blockade or spinal cord stimulation, are other options. Practice points. An integrated multidisciplinary approach to pain management is often required for both acute and chronic pain. Patient involvement in the initial and continuing assessment of their pain and treatment is essential. People with a history of substance misuse may require higher doses of analgesics to manage their pain effectively. Liaise with local drug and alcohol services regarding their care. If this lesson helped you, don't forget to hit that subscribe button. Please share this video. You never know who might need the right information to ace their exams or become more clinically sound. Let's grow together, learn, revise, and succeed.